All right, we've got a lot of folks joining us. So once again, thank you so much for joining us today for our presentation. For those of you who I have not had the pleasure of meeting, my name is Rebecca Bedeau, and I'm the Director for Strategic Communications at the Betty Irene Moore School of Nursing at UC Davis. Before we get to our presentation today, focused on meeting the needs of diverse caregivers in California, Dean Stephen Kavanaugh from the Betty Irene Moore School of Nursing would like to say a few words. Dean Kavanaugh is the Dignity Health Dean's Chair for Nursing Leadership and a professor. He has a passion for healthcare workforce development and maximizing the use of advanced practice nurses. His research explores the understanding of innovation within nursing and the rise of technology in healthcare. Dean Kavanaugh.
Oh, Rebecca, thank you very much for that introduction. And thank you for so many people for being with us on this very exciting afternoon we're going to share with you. At the Betty Irene Moore, our research focuses on family caregiving, healthy aging, and technology-enabled solutions to the very complex healthcare situations that we try to find solutions to. Our speakers today bring great expertise in those areas. I'm delighted to introduce to you first Dr. Heather Young, who is a nationally recognized expert in gerontological nursing and rural healthcare. Her research focuses on healthy aging with a particular focus on the interface between individuals, family, and formal healthcare systems. She also was my predecessor here and was the founding dean of the Betty Irene Moore School of Nursing here. She also serves the important role of being Director of Strategic Initiatives to our Family Caregiving Institute. Our second speaker is Dr. Janice F, who is the school's Associate Dean for Research and also holds the Western Health Advantage Endowed Professorship. She is an accomplished health services researcher who has co-created innovative care models for older adults with illness and their family members. She also serves as Director of the school's Family Caregiving Institute. I look forward to this very interesting discussion, and I'm sure the many questions that will emerge from it. Rebecca, thank you very much.
Thanks, Dean Kavanaugh. Well, there are more than 40 million family caregivers in the nation, providing care, unpaid care to family members and friends. This number is actually expected to grow with the increasing older adult population and the growing need for complex care in the home. As Dean Kavanaugh mentioned, the School of Nursing's Family Caregiving Institute was founded to advance systems of support for those often unsung heroes. Many of you joining us today may find yourself in that role in your family. Our institute leaders seek solutions for those of you providing care and to bridge evidence from practice to policy. Doctors Young and Bell together lead the Institute's Program and Policy Evaluation Unit, and they really assist state and community agencies in understanding their strengths and the opportunities for improvement so that they can achieve high quality, equitable services and supports for older adults and their caregivers. I believe that term equity is going to play a part in today's conversation. So without further ado, I will turn it over to Dr. Young and Dr. Bell.
Thank you so much, Rebecca and Dean Kavanaugh, for the introduction. Dr. Young and I are delighted to be here today. I want to welcome everybody, and I want to say thank you to all the organizers who made this session possible. I'd like to start the presentation with the important words of our former First Lady, Rosalind Carter, who was a caregiver herself, and she very much valued caregiving as a critical component of our nation's healthcare system. She liked to say there are 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will need caregivers, and those who will be caregivers. So shown here in the center is my mom, and on the left is Heather's parents, and on the right is Heather when she needed a caregiver. Heather and I are both caregivers ourselves. We lost one of our parents in the last couple of years, and we're still caring for the other. And we bring this experience to our work and understand firsthand both the rewards and the strain that this vital role can bring. The Family Caregiving Institute here was launched in 2017 with a generous donation from the Gordon and Betty Moore Foundation. And this was part of the foundation's effort to improve care for people with serious illness. And we have 3 main goals. The first is to enhance the capacity of health professionals to engage with family caregivers. The second is to enhance the capacities of family caregivers to enact their role. And then the third is to generate research. And toward our research goal, we have developed the Family Caregiving Institute Policy and Program Evaluation Unit, which Dr. Young and I both co-lead. And we have a growing research team here, funding for a long list of projects. And today we're going to share some of this work and show you how research findings can be used to advocate for change. I know from some of the comments and questions that you all submitted before this presentation that many of you are caregivers yourselves. And there's several factors that unite us in this role. First of all, we have a significant personal relationship with the person that we're caring for. This could be a parent, it could be a child, it could be another relative or a friend with whom we have kinship ties. We provide support to help this person maintain their independence, their dignity, their engagement, and their quality of life. We do this without pay and without formal assessment. We experience emotional rewards and impacts on our own finances, our physical and mental health and social isolation, and we engage in increasingly complex care over time. So as we think about this increasingly complex care, there are several reasons for this. Older adults are living longer with more chronic disease, and as a result, when they're discharged from the hospital, they tend to be sicker and they're being discharged quicker. As hospital lengths of stay have decreased, we're finding that caregivers are having to do more and more complex care in the home. And this includes managing medical and nursing tasks that used to be under the purview of doctors and nurses in the hospital. So they're managing monitors or meters, they're taking care of pain, they're managing medications, sometimes they're managing respirators, they're performing wound care, and they're managing durable medical equipment. We're asking caregivers to do this while they're also taking care of the person's personal care, so activities of daily living like bathing and dressing, and then instrumental activities of daily living like helping with transportation and finances. They also participate in healthcare decision-making, and then they coordinate care often through with a lot of different providers. It's not surprising that survey data is showing us that many family caregivers feel ill-prepared for this role, and especially ill-prepared to do the medical and nursing tasks in the home. So here I'm going to turn it over to Heather to talk a little bit more about some of our work.
Thank you, Janice, and welcome everyone. I'm so glad to see you here today. And happy National Caregiver Month. November is Caregiving Month. And I just want to take a moment to honor and thank all the people who are caregivers out there and all of you who are supporting caregivers in any way that you can. It's a really important time for visibility for this important topic. I'm going to talk a little bit about the context for our work and give you some idea about what we're doing currently in the Family Caregiving Institute. Caregiving has been a research passion of mine for almost 4 decades. And over the course of a number of longitudinal studies of caregiving, we really came to appreciate the diversity among caregivers. There are among about 40 million, as Rebecca said, in the US, over 6 million in California, and they share those common attributes that Janice discussed, but they also vary along many dimensions, including demographics, the demographic characteristics. And Janice, could you please advance that for me? Thank you. Age and gender, sexual orientation, financial resources, all those kinds of things that are part of our sociodemographic profiles. They also vary by cultural background, race, ethnicity, and religious affiliation, which often carry expectations for caregiving in the family and how we work with each other to care for older adults and disabled members of our family. There are other factors, including our choices, our choice in being a caregiver, motivation, and also the kinds of competing demands that may play a role in the experience. And then finally, the characteristics of the actual caregiving situation, the demands, and also the resources available to caregivers. How long someone has been a caregiver, where on that trajectory many of the situations that people are engaged with take place over time, and the underlying condition the person they're caring for unfolds. And so where someone is in that trajectory will make a difference. Also, the kinds of things that they're having to do for the person, including the relationship quality, how well they interact with each other, and what the history of that relationship has been. Resources really vary as well, the kinds of connections we have, our social network, and the availability of others to help and to contribute to the caregiving situation. So all of these aspects of diversity really mean that there's no one size fits all when we understand a caregiver's experience, nor one size fits all for how we help caregivers and support them. We really need to be thinking about that there are many common needs, but there are also some special considerations. So back about over 8 years ago, the Betty Irene Moore School of Nursing partnered with AARP, the Public Policy Institute there, the Family Caregiver Alliance, and the United Hospital Fund to found the Home Alone Alliance. We're a group of partners who came together because we all care a lot about caregivers. We're concerned about policy aspects and services and supports available to this important group of people. And in the course of our work over the last 8 years, we focused on conducting research about caregivers, developing educational materials for caregivers, and translating our research into policy recommendations. And in 2019, we conducted a national study of family caregivers that identified the ways that caregiving is changing in this decade. And there were some important major findings that came out of that work. On the next slide, please. We found for the first time, really, the extent of medical nursing tasks and the intensity of care that people are providing in the home. That many of the things that I, as a brand new nurse, was terrified to do, family caregivers are doing at home, administering medications, wound care, and a variety of different other tasks. That the care is really complex, not just in terms of the tasks, but the nature of the problems that people are managing. Pain, extreme pain, chronic pain, cognitive and behavioral issues and needs. And we also found out in the study how diverse caregivers are in their experiences, particularly when certain characteristics intersect. For example, if you have a low income, you're in a rural community where there are few resources in the community, you're in an underserved community, and you're managing both childcare and caring for a disabled person or an older adult, your needs are really different from someone who has more resources in that situation. So it really helped us to hone in on the idea that we have to think very carefully about the intersection of a number of these diverse characteristics. Caregiving is becoming a national issue, and I could not be happier about that. It is National Caregiving Month, and this is something that we should celebrate. On the left is a picture of a report that was issued in 2016, Families Caring for an Aging America, that came out of the National Academies of Science, Engineering, and Medicine, and it documented the extent of family caregiving in the country, and it also really made recommendations for how to go forward. We were very pleased that they cited the Home Alone report in this national study. There have been a series of caregiving in the US surveys that have been done over the years. That's AARP and the National Caregiver Alliance. And this is another really important data source that increases visibility to policymakers about the nature of caregiving. And then in our own state, there's an effort that's around picking up the pace of change in California. And I'll talk with you more about that in a moment. Another exciting development that came along recently and was launched in 2022 was the National Strategy to Support Family Caregivers. And this really came out of a tremendous effort, the RAISE Act, which was passed by Congress in 2019. And it includes both the older adult and the disabled community in coming up with major goals. And this is a plan that really is targeted towards all levels of government, local, state, and federal, and the private sector, and charges all of these different entities to look at building a better system to support caregivers with the resources they need for their own health, well-being, and financial security, while at the same time they're providing vital support for people who need care. And there are 5 main goals out of this effort, and we're really pleased with the Family Caregiving Institute that we're helping to address a number of those national strategies. Then in California, we had some exciting developments recently as well. In 2019, Governor Newsom led the way with his commitment to older adults and people with disabilities by issuing an executive order to establish a master plan for aging. And this is an idea that all Californians should be able to age well. And so this was an executive order to form a master plan. I had the honor of serving on the Stakeholder Advisory Group, which was a very engaged group of people who over 2 years worked closely with many public forums to get input from all across the state about what was important. And out of that, we were able to come up with recommendations to the governor that he formalized by adopting the plan in 2021 to have 5 major goals. And there's a website here listed, and it's an interactive website. So you could go on this website and drill down and see what's happening. But as you can see, the goals really range across sectors: housing, health, inclusion and equity, caregiving that works, and affordable aging, the issue of finances. What was exciting to me about this was it was a cabinet level involvement, and that he really charged every single department within his government to think about these issues and to deliberate. Fortunately, this plan was issued at a time when there was a bit of a budget surplus. So it enabled some investments that were really aligned with the strategies that were developed within the Master Plan on Aging. And so we have a tremendous opportunity in California right now with demonstration projects and specific investments that are going to advance this agenda. I was really excited that the 4th goal is caregiving that works, and that's close to our hearts here at the Family Caregiving Institute. And in this goal, we crafted recommendations that had to do with family and friend caregiver support, but also recognized that the paid workforce is really significant. Most people want to age at home, they want to age in their communities, and it often takes some extra help, paid help, to be able to do that. And we recognize that not only does that paid workforce need to be trained and supported to do their care, but that it's a potential career avenue for people who are family caregivers and learn a heck of a lot more than they ever thought they would know. And then after their family member passes away, they have the skill set, and it's a perfect time to think about turning that into a career and potentially entering part of the paid workforce or pursuing education to become a healthcare professional. So there's some provisions in the master plan to enable that kind of career progression as well. And then also a recognition of technology and its role in healthcare delivery, and how important it might be to think of technology to support family caregivers in their homes. Out of all of that work, it really aligned well with something that Janice and I had started to work with in 2019 as well. The California Caregiver Resource Centers are a phenomenal source of support in California. And California really led the nation in establishing a statewide network of these resource centers back in 1984. And this state map shows you the regions and the counties that are served by each CRC. And it's a history of a service model that really combines a number of different elements. These caregiver resource centers are funded by the California Department of Aging, but they also administer funds that are federal, like the 333E funds and some of the county contracts. They also take money from donors. And what they're able to do is provide family consultations, support groups, education and training. And they also administer some vouchered services such as respite and counseling and legal consultation. So these entities have existed since 1984, but had become pretty decentralized as their funding had lapsed over the years. But in 2019, the state of California decided to reinvest and do 2 important things. One was enhance their investment to support services, to help this group become more of a statewide entity, and also invest in technology, into a platform, a web platform called CareNav, which is a proprietary software platform. And this platform was deployed, and over the course of the next 3 years, there was a process of deployment. And Dr. Bell and I were engaged as lead evaluators of the implementation of the changes within the CRCs. So the next slide, please, will show you a picture of Del Oro, which is our local CRC for Sacramento and Yolo counties. This is the web portal where you can go in, click in, and find information about CRCs. I'm going to tell you a little bit more about what is in this platform, though. CareNav is actually, it's cloud-based, it's HIPAA compliant, and it's interactive. And this is usually not the type of characteristic of a community-based website. These websites are really developed in such a way that are so secure for people to be able to share confidential information and to get the support that they need. On the CareNav system, clients, caregivers can go in any time of the day or night and complete an intake, answer some questions, complete an assessment. And with that, the staff at the CRCs get in touch with the family caregiver, review their information that they've entered, and ask further questions if necessary, and help to come up with a tailored care plan, as well as resources that are really tailored to the needs of that particular caregiver. And with that, they can also, on the back end of this online platform, generate reports and information about who they're serving. And this is really important for us as we think about equity and we think about quality of programs. This is a picture of the CareNav where you go in and you get started and fill in your intake information. It tells you who's on your care team. The next slide will show you after the completion of an assessment, there'll be an action plan that's generated down on the bottom left that says some very specific suggestions and ideas for care. And on the right, resources that are very specific to the needs of that particular caregiver. So our involvement now is working with this database, which is the first in the country to be as large and robust in understanding needs of caregivers, and we're able to do a tremendous amount of work with the CRCs in understanding who they're serving and what types of services are helpful. And I'm going to turn it back to Dr. Bell to give us some insights into that.
Thank you. So this Caregiver Resource Center model includes an intake when the client first signs up. That could be interactive through the CareNav portal, or it could be done over the telephone. And then soon after intake, the client gets an assessment, and the care consultant, who's usually a social worker, will ask about all the services that the caregiver is involved in. So are they doing medical and nursing tasks? Are they supporting activities of daily living? How many hours of caregiving they're doing, and so on. And then that same assessment, part of it gets re-asked at about 6 months so that we can actually track what's happening over time. And in between that intake and reassessment, clients get the consultation. They can have as many consultations as they need. They get resources and referrals. They get education, which could be individual or a community-based class. There's counseling and support groups. There's access to legal consultations, including grants that can help families with getting help from a lawyer if they need it. There's respite grants that will pay for someone to come into the home to sit with the person needing care. There are other supplemental grants to try to buy things like durable medical equipment, so things like walkers and canes. And then the CRCs also engage in media outreach so that the good services are available to everybody. So we were able to do some important analysis, we think, with the data from CareNav to try to look at who this population is that's being served. And it's a very large and growing database. So every day the care consultants are adding more information. So in just the 1 year that we looked at, which is 2020 and 2021, we picked that because we had 2 surveys, a state survey and a national survey of caregivers that were fielded in the same year. And so we could use the same year of CareNav data to do these comparisons. So we used the California Health Interview Survey, which is about 3,000 caregivers. And that survey happens about every 5 years, asking caregivers a series of questions. And a national survey called Caregiving in the US survey happens about every 5 years, asking a national sample of caregivers a series of questions. And you can see these are very large samples, and the CareNav data has even more than in both of those surveys. So quickly, we started to see that the Caregiver Resource Center clients were a very different population. So they tended to be older. About 40% were 65 and older, which was similar in the state survey, but the national survey showed more younger caregivers. They're also more diverse in the California Caregiver Resource Centers, reflecting the population of California, with just a little bit over half being white and non-Hispanic, and the rest identifying in other racial ethnic groups. When you compared that to the state and national data, we saw that 65% were white and non-Hispanic, with the remainder in other racial ethnic groups. So definitely a large sample of diverse caregivers in that CRC database. In this slide, you can see we were able to compare what we call care intensity. And the measure of care intensity was developed with an index that the AARP developed for the national survey. And the inputs for that are how many hours of care is the caregiver providing service, and then also how many activities of daily living like bathing and dressing, and how many instrumental activities of daily living like helping with transportation and preparing meals were included. And you see here that 90% of the CRC caregivers are engaged in what is categorized as high intensity care, compared to only 41% in the national survey. The caregiving hours per week are also higher. So we see 73% in the CCRC caregivers, 32% in the national, and only 9% in the state that are doing caregiving activities 40 or more hours a week. And also the CCRC caregivers were more often caring for someone with Alzheimer's or related dementia. So about 68% compared to only 5% in the other databases. They were also more likely to be doing medical and nursing tasks in the home at almost 80% compared to almost 60%. So further look at this measure of caregiving intensity. Again, this was hours of care plus the activities that are going on in the home. We see that this caregiving intensity increases with age. So when you go back to the, sorry about that, the high intensity care is the bright red bar. And you can see that as the caregiver gets older, up to 85%, that red bar is growing a little bit. So it's an increasing intensity as caregivers are getting older. We also saw more high intensity care among groups of caregivers who identified in any racial ethnic group other than white and non-Hispanic. And we saw more high intensity care among caregivers who were caring for someone below the federal poverty level. At the same time, we saw that the hours of paid and unpaid help were very, very low. So looking at these bar graphs here, on the left, you see unpaid help. On the right, you see paid help. And the very lightest blue represents 0 hours to 10 hours of unpaid or paid help. So the message across these two graphs is that most people have 0 to 10, so very little paid or unpaid help. These percentages, as you can see here, differ by race and ethnicity. We also saw less unpaid help with older age. Maybe as older adults, social networks are getting smaller. We saw less paid and unpaid help with lower income, and we saw less paid and unpaid help with rural versus urban residents. So again, showing these disparities or inequities in the amount of paid and unpaid help distribution. And then not surprisingly, the outcomes of the caregivers in the CRCs were worse. So they were more likely to say that their health was fair or poor as compared to excellent, very good, or good when compared with the state database or the national database. They were more likely to say that caregiving made their health worse at about a third compared to 20% in the national survey. And they were more likely to score as lonely on the UCLA loneliness scale, with over a third scoring as lonely compared to only 5% in the CHIS or state database. Looking a little closer at caregiver burden in this group, these are, it's the Zaret burden short form scale. So there's only 4 items in it. And those items measure feeling stressed, feeling strained, having no time, and feeling uncertain about what to do. And we saw differences in this burden measure by race and ethnicity. And we also saw higher burden among caregivers with younger age. When we looked at burden over time, we saw that at time 1, which is when the caregivers came in for assessment, the average burden score was 8.3. And when they came in for reassessment about six months later, that burden score had decreased a little bit. It's a very small magnitude, but it is statistically significant. And I think the important thing to think about here is that this small decline is happening over a 6-month period when you would expect that the care recipient's care condition is getting worse. So that makes it all the more important that this decline is happening. And we do think this attributes to the work of the care consultants and the resources that they're able to provide. We also saw at time 2, so again, red is reassessment here, that the percentage of caregivers with some paid help at 6 months was 22% compared to only 17% when they first enrolled. And again, we think that this change in paid help over time may be attributed to the hard work of the care consultants and the resources that they're providing. So in terms of impact and lessons learned, we do find across a lot of our work that caregivers reflect multicultural groups with very important differences in their caregiving experiences. We think that the CRC intervention can improve caregiver outcomes, and caregivers are certainly satisfied with the services. We did some important qualitative work this year, finding that these services made all the difference to this group of caregivers. And I think the important thing to think about when we look at the state and national survey data compared to the CCRC data is the kind of the way these populations are attracted to the data. So in other words, the CCRC caregivers are a help-seeking population. They are asking for help by phone or online. And so they're not a random sample. And the state and national surveys are random samples of caregivers, probably including people who have time to fill out surveys. And so they think that's why we're seeing such a big difference. So while the CCRC, the California Caregiver Resource Centers address the unique needs of the caregiver populations in their catchment areas, we are finding that the caregivers are involved in very intense and complex care in the home, that there we go, that the state and national surveys do not capture this intensity of care, and that the CareNav data is a really important addition to that kind of data that can be collected. We think it's a solid platform to support future adaptation of the CRC intervention, ongoing evaluation, and then dissemination in the future. So I'm going to turn it back to Heather to close the presentation.
Thanks, Dr. Bell. We're excited to be involved in the CRC project, and we're also involved in a number of other California Department on Aging projects around age-friendly communities, around adult daycare, day programs, and other initiatives. And so it's nice to see these pieces all come together. There are a number of areas that we think are really important for future work that we're engaged with, and we encourage others to be involved with as well. One is around community level planning. California is a huge state, and there's a lot of diversity across the counties with different assets and different types of resources and different people living in those counties. And so we really encourage, along the lines of the age-friendly community development, to think at community levels about what needs to happen for the kinds of services that not only meet the needs, but reflect the community. We also recognize that health promotion is vital, that if you can avert being a caregiver or needing care, the longer you can do that, the better. So health promotion is always important. And for caregivers to sustain their roles, they need to be able to attend to their own health and also benefit from respite, getting others to help and others to be engaged in the care. Isolation is a big issue. Loneliness among caregivers is much higher than in the general population, and finding ways to connect people through support groups, through other avenues, through community organizations to address isolation, which is a really big threat to health as well. The systems of care and coordination can greatly be improved. Oftentimes we've had community services working in one area and health systems in another, and not communicating enough to be able to support care across the continuum. And so improving our systems of care and the way we communicate and coordinate is also vital. Health equity and disparities is a public health safety issue, the extent to which there are disparities in health and healthcare. And we are really excited to be working with the state on developing an equity plan for caregivers. And in the course of that work, what we're going to be doing is using our data that we have that Janice has been sharing, and other data as well, to identify gaps in services and supports for caregivers along several dimensions of diversity, including race, ethnicity, rurality, veteran status, sexual orientation, variety of different areas, to identify potential strategies to fill in these gaps and to develop a plan for forward progress. And we're working with the CRCs on this, as well as other advisors and experts and caregivers and care recipients themselves, to develop an equity plan. We also want to map what's going on in California to the national strategy to see where there's opportunities where we're actually leading and should disseminate our work, where there are opportunities for growth and learning from others as well. Technology plays a big role. The CareNav platform is an example of a technology to provide resources, but there are many other technologies that help someone to stay at home safely, providing monitoring and support and communication. Another really important area is around caregiver-friendly work environments. About half of caregivers are working, and they're juggling the demands of caring for a family member or a person, an older person or a person with disabilities. And our work environments are not necessarily as friendly as they could be, with paid leave, with issues around flexible scheduling and supporting people who are grappling with these important life issues. And then finally, emergency preparedness. The wildfires we've experienced in the last few years really bring home the needs of caregivers and persons who need their support. Our typical plans don't include them well enough. And then when people are evacuated, for example, the facilities where they go don't always have the services and supports necessary to manage their conditions in that setting. So there's a lot of work to be done. We're excited by this work, and we're really thankful that you're here to hear about it with us today. We wanted to, before we leave you, just give you some resources that are important. This is a link to the videos that we've developed with AARP. There are over 50 videos now, and they are about 3 to 4 minutes long each, and they have topics that are listed here and more. And they provide very specific feedback and support for family caregivers trying to manage these complex tasks. So if you need this or you know someone who might, please share this link. And then I'd also like to share some community resources. This is the link to the California Caregiver Resource Centers, the top one. If you click on that, you can get access to all 11, whatever your local one would be. For information about adult daycare, on the California Department on Aging website, there's very specific information. They also have a lot of good information on their website about general services and decision-making and the kinds of tools you might need to manage. And then the Alzheimer's Association is also a font of information for those people who are concerned about someone who's living with Alzheimer's disease or a related disorder. So I'll pause there and just want to say you make a world of difference if you're a caregiver. Thank you for doing what you do. And we're really eager to hear your questions. Thanks for being here.
Well, thank you, Heather and Janice. Eye-opening, not only from the data, but from the existence of caregiver resource centers. Several questions have come in from people saying, how do you find out about this? Where do you learn about Caregiver Resource Center? For a second, I just Googled while you were talking, help for caregivers in Sacramento, and the Del Oro Caregiver Resource Center popped up, and then farther down the CRCCs. So how can people get out the word and learn more about the Caregiver Resource Centers?
Yeah, this is such an important issue, and we've asked caregivers at the CRCs how they heard about it. A lot of it is through healthcare providers and social service agencies. So we need to make sure that we're getting the word out to our professional colleagues so they can make those referrals. They also have a much more of a social media presence than they ever have, and they're working very hard to get out there onto the typical kinds of platforms that the public is on. And word of mouth is a big piece as well. So spreading the word. We're really lucky that there's a central place. If you look for caregiver resources in California in a search, you come up with it. And so it is there. But you're right. It's one of the biggest challenges of getting the word out. It's a really hidden treasure in our state.
Yeah, I'll just add that the data does show that the biggest way that people find entree into the caregiver resource centers is through their healthcare providers. It could be social workers, nurses, doctors, and then the second is through word of mouth.
And presentations like this.
And presentations like
the CareNav feature, is that just in California, or is that a nationwide portal?
So the portal is in California, but people can enter it really from anywhere. And we have got a small number of people who have filled out assessments from out of state. We can't provide them services because the state is funding the services, but are able to sort of help them to find something in their local areas. But it is open to anyone.
Okay, another question, or actually a combination of questions that we had submitted before the presentation, really were focusing on folks needing help in their unique caregiving situation, concerns about cost, finding paid help, a lot of the things that y'all were actually, looking at in your data, communications challenges in the context of dementia, getting help for depression, finding respite care, getting support from the healthcare system. So I know you can't address all those individual questions, but what would you say to family caregivers who are struggling with specific issues related to their caregiving role, and what they can do to get started and find the help that they need?
Do you want me to start?
Sure. You go
Sure.
first,
So
I'll
I
follow.
would say the first stop is to head to the California Caregiving Resource Centers, especially if you're in California. If you're in Yolo or if you're in Sacramento County, that would be Del Oro. And through that, it opens doors to many, many other resources. So that is for like immediate help for yourself and your family. Other resources, Heather did mention the AARP website has a treasure trove of videos and fact sheets and all kinds of information about specific situations, as does the Alzheimer's Association. Our FCI website has some information. And then here at UC Davis, there's the Healthy Aging Clinic, where caregivers can get a consultation for themselves while their person who's needing care may be getting seen by the provider. And that could be a helpful entree to some of these services as well.
Heather, I'll ask this one to you. What can caregivers do in advance to prepare for the care recipient's health decline? And I'll add, we see that the caregivers also have a health decline as well. So how do you prepare, and then how do you look out for your own health in the process of caring for another?
I think that's a great question, Rebecca, and it applies to you even before you ever think you need care or you're going to be a caregiver. I think part of it is having the conversation with yourself and people who are close to you about what's important to you. What are your values? What are your preferences? What would you like to see happen as your life unfolds? And with that, putting that in a way that's memorialized. So it's about planning, thinking about instruments such as advanced directives, where you actually say what you want and you identify a person who can act on your behalf. It may or may not be your caregiver, but it's a person who can act on your behalf. And importantly, writing it down and having a document, but discussing it and updating it. In my own situation with my parents, they did this years ago, and I'm so thankful that they did. And I'm really thankful we had conversations because they wrote it down. I was surprised by some of the things they wanted when I sat down and asked them, now, what do you really mean by this? If this happened, would you want that? And I learned things from them that I assumed I knew. So the communication is absolutely vital. So having that in place, and the preferences around things such as where would I want to live, who would I live with, what would I be willing to accept, and understanding that, having that understanding in advance of a crisis makes a really big difference.
So in looking at where will I live, how will I live, that's another question we got. What is better for an older adult? Stay in your home with a caregiver or move to an assisted living facility?
You know, there is no one size fits all answer to that. What I would say is you go back to the process of what do I value? What's important to me? If I'm thinking about staying at home and that's my value, who's there to support? What kinds of support can I mobilize? What is my financial situation like? Can I afford to get additional help if I need it? Is my home even amenable to that? Does it have stairs and things that wouldn't work for me if I became more disabled? So it's really about assessing what you want and your environment around you, and to see where the best opportunities are to support your goals. For some people, you may be living in a home you've lived in for 40, 50 years, and you're living there by yourself, and it's too big to manage, and you may not have the kinds of supports you need. And in that case, a move may make a lot of sense. So it really is very individual, but it's about that process of thinking about what you value and what resources are available to you to make your goals come, reality.
Speaking of resources, I don't know if we can get that slide up from your president, Janice, if you can get the slide up with the resources. We have some folks who might like to view those, and we'll be able to share this with you later as well. But, Heather, you really bring to light this what matters piece, right? That's one of the 4 M's of age-friendly health systems. And I'll throw in another thing that the UC Davis Health has, the Healthy Aging Initiative, which is bringing together clinical care, research such as what Heather and Janice are doing, as well as education for the future healthcare providers who will be caring for an aging population. So those age-friendly efforts are really looking at the what matters piece, because just because we're getting old doesn't mean we don't have opinions and attitudes about what we want for themselves. Why do you think people shy away from having these conversations until someone is sick, or it might be a little too late to start planning?
I'm not sure why people don't have the conversation. I think it's uncomfortable. We don't want to think about our own mortality. But I think there's also the issue of social isolation that occurs when people are getting older. Sometimes that decision whether to go to assisted living or to stay in one's home may be dictated by sort of the need for community, where, you know, people, I remember as my parents were getting older and older, their whole support system was dying before them. They're in their, my dad is currently in his 90s. So I think that's an important piece of that consideration as you begin to have the conversations as well.
We have time for one more question because you mentioned it. You mentioned you were working on an equity plan. Can you give us a little insight into what this latest research is for California and how everyone will be able to benefit?
Absolutely. So it's an exciting effort, and it's about using the data that we have from CareNav now with so much rich information, as well as other data sources in California about who are the people of California and what do they need and want. There was just a recent study that was fielded in California around it was called the California Survey of Older Adults, and it went out to 28,000 people responded. So there's new information about what people perceive as being available to them and how they perceive the adequacy of services. So we're going to look at this data in California and try to understand, even at the zip code level, what's going on and identify where some of the gaps may be. And we know, for example, already from the CRC work that most of the resources are in English. There's some in Spanish. There are a few resources in Vietnamese, but there are so many more languages spoken in California. And so one big gap we already know is language access to services and supports. So we're going to be looking at mapping that and working with people who can help us understand the data, because we wouldn't presume to be able to understand it ourselves. We really need others to weigh in and look at it and help us to interpret that. And then with that, we'll be engaging the CRC directors and others to think about, well, what could be done and what are some reasonable strategies that can be recommended to develop a plan for the state to go forward and address the gaps. Janice, do you want to add anything to that?
No, I think we have a lot of local leaders who are California-based leaders who will be on an advisory committee working with us closely. We have both an internal and an external advisory committee. So as Heather mentioned, this is going to be crowdsourcing ideas for solutions and in developing that equity plan.
And because you're working at such that high level, the maximum impact of being held statewide for all the individual service agencies that are giving that direct report just has that much more potential. So we're excited. We will definitely be sharing that work. And thank you so much, Deb, Heather, and Janice for sharing the work today that you did. I'm quickly running out of time, so I'm getting trapped up, but I just want to express our gratitude for all of you who joined us today. You know, the impact of the Betty Irene Moore School of Nursing at UC Davis is really amplified through philanthropic support. Whether your interest is in supporting patient care, research, like what Janice and Heather are doing, or really educating the next generation of scientists, physicians, nurses, and care providers, we're ready to assist you in finding the impact that your gifts can make to UC Davis, the world, and beyond. So if you're interested in that, I invite you to contact Carrie Cloud. Her information is right there. And a big thank you again to Dr. Young and Dr. Bell for taking time out to really share this valuable information with our audience. I think a lot of people left today with a checklist of things to do and great information to share with their friends, family, and community. On behalf of UC Davis, we hope that you stay well. We hope to see you soon and have a wonderful holiday season ahead. Thank you.